Hey, good afternoon, good people. I hope everybody's doing all right. It's Dr. Q Jordan with Fearless Physical Therapy. I hope everybody's having a great day today. Today we're going to go over just dealing with the frozen shoulder, different techniques to kind of help you improve mobility, help you improve strength, overall improve function while hopefully decreasing pain. Just remember that not everybody's shoulder is the same. So what works for one person is not going to work for another person. So that's why it's imperative that you be seen by a physical therapist such as myself to actually get a program that's going to suit you and your needs so that you can get better. All right. So without no further ado, we're going to get started. I'm going to share my screen. Boom. All right. So hopefully everybody can see this. Once again, we're doing thawing out the shoulder. Dr. Q Jordan, PT, DPT. There's some more letters after that, but after a while, doesn't really matter. Those first two are the important ones. All right. So basic anatomy lesson. The shoulder joint is a complex system of four joints working as one. If there's an issue with movement at one part of the shoulder, then the others will start having problems because an issue at one affects the other three. To get to the extremes of motion in the shoulder joint, also has to have movement in the neck and the thoracic spine or the mid back. For functional activities such as eating and bathing, motion has to also occur in the elbow and wrist. So all of these joints during an assessment have to be taken a look at. All right. Most of the motion at the shoulder occurs in the glenohumeral joint. That's the ball and socket joint of the shoulder. But there is a kind of rhythm or play that occurs with the other joints. So for every about 4 degrees of motion that occurs in the glenohumeral joint, that the SC joint, which is you're at your sternum or is connected to your sternum, has about a degree of motion. If that play is off, you can still get full motion, but it's not going to be in a smooth pattern. And a lot of times you see that herky-jerky motion if it looks like somebody's trying to fight their way up. The shoulder stability, because it's such a mobile joint, is due to the joint capsule, which surrounds the joint, ligaments, which connect bone to bone, tendons, which connect muscle to bone, and of course the muscles, which we think about as the prime movers of the shoulder. All right. Sorry, I just got a text message. Okay. So this picture right here is basically just what the shoulder looks like at a glance if you took away most of the bones. So you see we have right here the acromion and the clavicle, which together forms the AC joint. You have your glenohumeral joint, which is the humerus or your funny bone, and then the glenoid cavity. And as you can see, so the scapula is right here, and we have cartilage. You have ligaments connecting bone to bone. You have the muscle. This is one of the many bursa that are in the shoulder. And so right here we have This slide right here is just going over the basic average range of motion for the shoulder. Now, it's important to understand that these values are just the average for the population. What's more important than these numbers is comparing the arm that is problematic to the other arm, because not everybody has 180 degrees of flexion. That's the motion when you bring your arm up over your head. Some only have about 170, and that's normal for them. And so there's different normals for each person. They're usually within about 5 degrees of this range, but it's more. I have to reach a lot higher to reach that same shelf. So that's also important. Do you have enough adequate motion for you to do what you need to get done? So these next couple of slides are just showing some of the basic motions. This is my middle daughter, I'm sorry, K2, and she's going, she's right now showing you what's called scaption. So this is the motion that you normally do when you're reaching up to grab something. I know a lot of people think it's it's flexion because you're just reaching up, but no. Normally, when you reach up, you reach into what's called the scapular plane, and that's this motion right here, scaption. The next one she's showing is external rotation. Now, this is the motion for people that go to reach behind their head to like scratch their head. This is the motion when you're brushing your hair, you're washing your hair, things like that. The next motion K2 is showing is abduction. This is the side motion onto the side. Now, with a lot of shoulder injuries, you'll see that the external rotation, the motion that I just showed you before, and then this motion are two of usually the most problematic motions. But right here, she's doing shoulder abduction. All right, so here we have a picture of the back, which the muscles here play a big factor in what goes on in your shoulder. So the first muscle we have is the trapezius. It's this muscle that's here, here, and it goes down to here. And it's on both sides. The right side is resected. But the trapezius is a muscle responsible for pressing overhead, and at a certain point, it also helps with abduction. Next, you have your levator scapula, which is this muscle right here. And let me go to the pointer, so hopefully you can see that better. So right here is the trapezius. Here is the levator scapula. The levator helps to rotate the head to the sides, which is important because when you're trying to reach above your head, you're trying to reach all the way above your head. To get that last little degrees of motion, you have to be able to turn that head from one side to another. If you can't, that's going to cause a change in motion. Next, we got this big muscle here, which is the lats, the latissimus dorsi, which helps with pulling motion, such as pull-ups. Also helps with pulling towards you. So any type of roll, the bent over roll, the horizontal roll, anything like that is what this is going to do. This is also a big important muscle when you're doing deadlifts. All right, so first video we're going to watch is a couple exercises to help improve shoulder joint motions. And so this is an overhead press in a row. Okay, so 4 shoulder exercises to strengthen those back muscles, which helps keeps your shoulder in place and keeps it stable First, we have an overhead press. You can do it multiple ways. One way is take a dumbbell. You're going to hold it about at ear level, and you're just going to press straight up, and then you're going to come back down. You're going to press up, and then you're going to come down. Or you can take a band, same thing, hold it, press straight up, and back out. Now, you want to keep the band the same distance the whole time, so none of this when you're pressing up. Whatever resistance you start with, that's what you want to keep it. And so you're going to press up and back down. All right. Next exercise is a lawnmower. It's just a variation of a bent over row. So, what I'm going to do, I'm going to put my one hand on the couch, one foot in front of the other. All right. And it's just going to be, I'm going to hold my hand that has the weight. I'm going to hold it over the other foot, and I'm just going to bring it back like I'm pulling on a lawnmower. So I'm just revving it up, and I'm doing a little rotation with it. Then another one. I'm going to bring it straight out to the side. And then down. And for a variation, I'm going to bring it up and forward a little bit, make it more of a Y. And then with my thumbs up, I'm going to make an I. Okay, so more shoulder exercises to strengthen those back muscles. Now, this next one is a scapular retraction, working on those parascapular muscles, which is so important for keeping that shoulder in place. One thing to note is that K1 has a tendency to shrug his shoulders up, and that's a little bit because of the upper traps are stronger than the middle and lower traps. So that'd be something, if that was an issue with he was having problems with his shoulder, we would work on. Okay, it's Fearless Physical Therapy. Today we're going to show you a couple easy shoulder exercises to work on strength and stability. Remember to always be evaluated by your physical therapist before you start a treatment program, because sometimes it could be your mid-back or your neck that's actually causing the problems. So what my assistant is going to do right now, he's just going to squeeze his shoulder blades back. And you see he went up. So once again, you just remember to squeeze back and then back down. So squeeze it back and relax. And you want to make sure you're going back and maybe backing down and not up. And so he's just going to squeeze back and down. Squeeze. All right, so those are a couple videos showing a couple shoulder exercises, mainly focusing in on that back that we just had a picture of. All right, so now we're going to get to the joints in the shoulder. So the first one we have, what everybody normally thinks about when you say shoulder joint, it's the glenohumeral joint, a ball and socket joint, basically meaning it looks like a ball in a socket. That little game that we used to play when you had a little cup and you try to get the ball into the cup that was attached to the string. That's basically what it looks like. Except for this, instead of the cup being bigger, the ball is a little bit bigger. Because the ball is bigger, it has if there was nothing to keep it stabilized, that joint will be very, 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 very loose. I mean, it'll be flying up into space almost. So to help stabilize that joint, you have the joint capsule, which includes everything outside of the joint. So basically, the bursa, the cartilage, the labrum, things like that. You have the tendons, You have the ligaments and the muscles. So we're going to show you a distractive exercise now for that. Now, this exercise distraction usually feels good for most people. But once again, before you try something like this, you do want to be seen by somebody. Now, if you're probably noticing, I'm just looking at the still that it's not a straight pull off to the side. That's because of the orientation of the glenohumeral joint. You need to actually pull away from it a little bit and a little bit up to get that separation. All right, so we're back again, and this time for the moment and back in. And that's going to help with. And you see, as he did that, as he stepped out to the side, you started to see a little bit of separation in the shoulder. All right. So the next joint in the shoulder is the ACR, acromioclavicular joint. It's basically, like as I said earlier, where the clavicle meets the acromion. It allows for protraction and retraction. That means pulling your shoulders forward, pulling them back. Basically, trying to separate your shoulder blades and try to make them squeeze and touch. This is probably one of the. This is a very lax joint in the body. It's not the one that has the most laxity, but it's pretty lax. The next joint is the sternoclavicular joint, the SC joint. It's attached to the joint. It's attached to the trunk. This is the joint in the shoulder complex that's attached to your sternum. A lot of times you see people who have injuries at this joint are in the shoulder. They may have one part of the SC joint that's a little higher than the other, or it looks a little puffy when you compare it to the other, and that can limit motion. A limitation here is going to affect every motion of the shoulder girdle, because this is basically, if you think of like a crankshaft on the little Jack in the Box, it's kind of starts the motion going. That everything else kind of moves about that. And it's also a latch joint. You think about it, all the football players like, who was it? The quarterback for the Packers, Aaron Rodgers, and some of the other quarterbacks, they end up injuring their SC joint due to being hit or whatnot. Or if they don't injure that one because of how they fell on the shoulder, they injure their AC joint. Now, this is a picture of the shoulder from the front. So it'd be, if you're talking to somebody and you're looking dead at them, you see your glenohumeral joint right here. So this is the humerus, this yellow bone, and then the head or the ball, and then it fits into the socket. This will be your AC joint right here. This is your coracoid process. This is the clavicle. It doesn't show you the SC joint, but that's the clavicle connects to the sternum. And you can see some of your you can see some of the muscles here. You see your biceps. You see the supraspinatus right here. You see the subscapularis, and you also see the tendons to the other rotator. Actually, no, I'm wrong. You don't see the infraspinatus, which is another one of the rotator cuff muscles, but you do see the teres minor, which is right here. So once again, that would be supraspinatus, the teres minor, the subscapularis, and then you got your biceps. Once again, we have a bursa. And there's a bunch of bursts in the shoulder. So if somebody says they have bursitis, it's kind of just taking a wild guess because you have a few bursts in the shoulder. So it's more of a which one is it? All right. And just to go over these muscles again. So you have sorry about that. You have your supraspinatus, which is usually the one people talk about when they say they have a rotator cuff tear. It helps with abduction, bringing your arm out to the side. You have your infraspinatus and teres minor, which help with external rotation. And you have your subscapularis, which along with the pecs helps with internal rotation. And you have your biceps, which I know everybody thinks of as being flexor of the elbow, but it can also help to elevate the shoulder. So right now we're just going to go through a few strengthening exercises with the bands. Just to kind of help you. These are usually exercises which you do with most shoulder injuries. And these are early stage exercises. So as you see, I'm holding one of the red bands, which is one of the lighter bands.
Good evening, gang. It's Dr. Q Jordan with Fearless Physical Therapy. We're going over some shoulder exercises in this series. So now we're going to do a couple shoulder exercises with a band. So first one, nice simple one, easy to do. Elbows in tight against the body. Take the band, hold it here, thumb up. All you're going to do is open out and close back in. Open. Want to keep those elbows in tight. This is working on those external rotators.
So that one was working on external rotation.
Good evening, gang. It's Dr. Q Jordan with Fearless Physical Therapy. We're going over some shoulder exercises.
And this is just the posterior view of the shoulder. So you can see here you have your supraspinatus again. You have the clavicle, your AC joint. You have your infraspinatus and your teres minor, which once again help with help with external rotation. A lot of times with external rotation, even though you see you got two muscles right here that help with that motion, because the subscapularis gets so tight, so tonic, it limits a lot of the motion into external rotation. So one of the things you have to do is to work on decreasing the tone. So a lot of high rep, low load activities to just get the blood flowing and to get that muscle to relax a little bit. Okay, we have a video here going over a couple, actually a mobilization exercise for the mid back to help decrease pain.
Another thing with shoulder injuries, what we need to focus on is neck and thoracic. That's your mid back, the mobility of those joints. Because a lot of times in order to get up to this point or reach up high or even reach across your body, those joints need to move. So one easy exercise I usually show my patients is they're sitting in a chair with a back to it, put a towel vertically along their mid-back, so starting from the base of the neck and to however long the towel goes. You're going to lean back into the chair, hands behind your head, and you're just going to look up and then back down. You're going to look up for about 3 seconds and then back down. And up, and you're going to feel your back start to arch and extend. And the stiffer you are, you may feel a little bit of a release, and then back down.
All right. So now we're going to talk a little bit more about what adhesive capsulitis or frozen shoulder is. Now, contrary to popular belief, there's no one main cause of adhesive capsulitis. I hear patients all the time say that I got adhesive capsulitis because of I have diabetes, or I have adhesive capsulitis because I fell on my shoulder. That may contribute to it, but that's not per se the main cause. A lot of people with diabetes never end up with adhesive capsulitis. A lot of people who've injured their shoulder never end up with adhesive capsulitis. There are other things that usually come into play also. Now, it does usually come about because of another issue at the shoulder. Now, what happens is motion is usually painful after some type of shoulder injury, and the person begins to not use their full motion, and the shoulder starts to get stiff. Now, when a motion becomes stiff and the muscles get tight, trying to move them in the opposite direction becomes painful. So now you have shortened muscles in your shoulder. So you go to do an activity like reaching up above your head, or reaching behind you, or reaching into the back seat with that shortened motion, and it becomes more, you get that pain response. And what you do after you get that pain response is you begin to limit yourself in doing those motions. And what that does is, okay, so you start limiting yourself more. So now you're only going about 50 to 75% of the way. And so you try to do something that goes further than that, and there's more pain. And then you start to limit yourself more and more. And so it becomes one big tragic cycle. And that a lot of times ends up leading into the adhesive capsulitis, or AKA frozen shoulder. Now, diabetes is seen often in people with the diagnosis of frozen shoulder, but part of that is more so because diabetes slows down your healing process. It doesn't allow you to heal as fast, so you stay in that aggravated state a little bit longer. So being in that aggravated state, that slower healing state, allows the body to get more adapted to not moving, because it's not healing it's not healing as fast as it should. So something that may have taken a month or two lasts 4 or 5 months. And so 4 or 5 months of your shoulder hurting, you're not going to move it as much as you would if the injury only lasted 2 months. So that's an extra 2 to 3 months of it being shortened. And so when you do try to move it, there's going to be more pain. Now, in most clinical cases of frozen shoulder, external rotation is limited first, and it's usually the greatest limitation. External rotation, remember, that's the picture of my daughter where her hand was up and she was reaching behind her head. That's one of the main times you use external rotation, when you're washing your hair, when you're doing your hair, things like that. When you're reaching behind your head is when you use that external rotation. Now, there are 3 to 4 phases of frozen shoulder. There's a pre-freezing phase, a freezing phase, the thawing phase, and then the pre-freezing phase, the freezing phase, the frozen phase, and then the thawing phase. What happens is, a lot of times, the reason why it goes through these phases is because you initially have the pain. Symptoms tend to get better, but they haven't gotten completely better. And so you don't really worry about it. You just kind of altered how you do things. And then so going with at an altered state for a while, you try to push it one day, or you come up with another small injury. But since it wasn't back at 100%, you're not at that 100% level to heal. So you're at a lower level. And so trying to heal back from that lower level, it causes a decrease in function. So you get this kind of this roller coaster type motion where you start off doing good, then you have the injury, you kind of drop back to about 80%, and then it goes well, then it dips back down for some reason or another, and then you try to go back up, but it doesn't really go back all the way to that, at least that 80%. It's usually more about 75, 60%, and then it drops back down again because of something happened. And usually people don't seek treatment until sometimes 6 months, maybe a year. I've had people that have been dealing with this off and on for 5 years, and it finally got to the point where they couldn't take it anymore. So they they finally come and see me. But if they had just came to see me earlier, it would have been a better prognosis for them. You can still get them back functional, but the earlier you see somebody, the easier it is to get treated. And so we're going to show you an exercise, as I talked about, working the subscapularis, that the muscle that does internal rotation, which is the opposite of external rotation. So you kind of want to work that opposite, the agonist muscle, the opposite muscle to if it's shortened, to decrease the shortening to allow the it to go in the opposite direction. So if you have a shortened subscapularis, it's going to make going into external rotation a little bit more difficult. So this is just trying to get that strengthened and lengthened out a little bit and to go for the external rotation. So that's the next video. Just promoting some blood flow to that area.
So now we're going for strength of the internal rotators. So we have the door anchor, we have the sports tube, and my assistant is just going to bring his fist into his belly button and then let it back out. And then back in and out. So you want to make sure that you keep your shoulders in plane.
All right, and so what I was talking about is you don't want your shoulder to roll forward or back. You want to kind of keep your shoulder at the spot. If you start to let it roll forward or start to let it roll back too much, you start to begin using other muscles. And which at times is a good thing, but if you're focusing on one specific activity, you want to try to be as specific as possible. All right, and so these are just usually the time limits, are the what has been reported in studies for the time limits of frozen shoulder. As you can see, the freezing stage is the first 2 to 3 months. Then you have the frozen stage, which is about 6 months, which can last about 6 months, I should say. Then you have the thawing stage, which can take up to 2 years, a lot of times more than that. Now, it should be noted that these numbers aren't set in stone. They aren't hard and fast numbers. Nutrition, activity levels, overall health, and other factors play into the healing process. Stress and poor sleep can grind the healing process to a halt. So if you're not eating right, you're not sleeping well, you're not in a good emotional and mental state. All those factors can cause the healing process to prolong or even grind to a halt. Not getting the proper amounts of minerals in your nutrition, such as magnesium, calcium, sodium, and potassium, phosphates, that can also slow down the healing process because your body uses these to stimulate the growth of cells that stimulate muscle growth, bone growth, and stimulate the healing process. So your diet is very important. If you're not getting the right things put in your body, it's going to slow down the process. I talk to my patients a lot of times about diet. It's like, okay, when you're recovering from an injury, that's when your diet really needs to be on point. I love shellfish. I love shrimp, crabs. If I could, I'd eat them all the time. But if I have an injury, stuff like that is going to increase the inflammatory process and it's going to make the healing time longer. So that I need to watch out for stuff like that. You got people that you see knocking back sodas left and right, stuff like that. The more you put into your system, starts to strip away things like calcium, which is going to be important for stimulating bone growth, and it also helps process slows. You're not going to be as active because you're cranky and sleepy. So all of those things play into account. So this says it's going to take 2 years, but that's not hard and fast. You can do things to slow down to slow down the healing process so it takes longer. Excuse me. You can do things to slow down the healing process so it takes longer, and you can also do things to make it quicker. Like if we see a patient early on in the initial stages of his shoulder injury or aggravated his shoulder, their prognosis is usually a lot better than that person that waits all summer and a day to come in, because we have less problems to get through. Those that kind of let things compound on them and just let it get worse and worse over time, we can still help you get better, but it's a lot of work. It's a fight. I mean, it's almost like Sisyphus trying to move that boulder up the mountain. I mean, it's going to eventually get there, but it's going you got to put in the work. I mean, you really got to work hard. So the earlier you get into somebody, also helps improve your prognosis. So once again, making sure that your nutrition is on point, your sleep habits are on point, your ways of coping with stress are on point, your exercise rates. Another thing, when you exercise, it starts to get the blood flowing. Your blood carries natural painkillers in it. So exercising, especially when you're hurting, helps to reduce the pain. And it doesn't have to be necessarily exercising that one joint every day. Like after I hurt my back, me just doing shoulder exercises and leg press and whatnot helped out. Now that does those muscles do stimulate the back also, but even if it was even when it was my knee after I injured it in wrestling, worked out, did a lot of heavy chest stuff, and then just doing that start to get the blood flowing, and it put me in a better state, and it made me tolerate the exercises on my knee a little bit better. So yeah, nutrition, exercise, all those things help out. Now we're gonna go into a couple other treatment videos that I use with people with frozen shoulder. So, but first, before we do that, I want to say that day one of therapy is consist of you describing your symptoms, what limitations you have, your history and specific goals. So you can't go in and not talk to the therapist. You had to let them know from the jump what problems you're having, what activities increase the problems, what makes it feel better. And please have a list of specific goals in mind. Yes, we understand that you want to decrease your pain. Yes, decreasing pain is great, but decreasing your pain to do what? Yeah, decreasing pain is always a goal, but decreasing pain, if you give us something a little bit more concrete, like an activity to get back to, it helps us out more. So like maybe you want to be able to decrease the pain so you can, this is always the one I get, so that you can put on your bra or comb, wash your hair so you can look presentable for work. That's a great goal. It may not seem to be too much, being able to wash your hair or comb it. I mean, especially if you're like me and you're going bald, but being able to do stuff like that is important. Another thing, expect that there are going to be times where it seems like you're plateauing off, and that's just normal. Working out, playing sports and whatnot, there were times in that process where it felt like I just plateaued. I was trailing off. It wasn't getting any better. And just know that when that happens, it's time to kind of change it up. But you have to report stuff like that to the therapist. We're going to ask you questions, but you got to be vocal. You got to be verbal with us. And your program is going to do things like work on improving range of motion and strength, which is going to help to reduce pain, improve function. It's going to work on improving your control, your coordination, things like that. And that's another reason why I said it's good to have goals, functional goals, because it can give us an idea of what we need to help you work with. So this first video, it's going to show you, I believe it's external rotation. So when you start working on that. So after we start getting that motion, anytime you start to gain motion, you need to work on strengthening that motion so it's not lost. I've seen people plenty of times in clinics who they get motion, but they don't work on strengthening it, and they come back and they're back at square one. So you gain motion, you strengthen it. If you gain the range of motion that you got, you need to make it strong so you keep.
Is that as you get near the end, you're able to go a little bit higher with this. And so we're going to let him do a couple. All right. And now the last one is a punch. So you're going to lay flat on you.
This is one muscle that I didn't really talk about, but it's another important part of the treatment process. It's working on the serratus anterior. It's the muscle that's important for overhead activities. So anytime you have to lift something over your head, it's another one of those muscles that you need to have working for you. And if you got to throw a punch, and you may laugh at me saying that, but you never know what you encounter where you might have to be able to knock somebody out. It's always important to be able to throw a punch, and that serratus anterior helps to throw that big punch.
Take the weight of the water bottle in your hand. You're going to hold that arm straight up, and you're going to lift the shoulder up off the table, basically separating your shoulder blades from each other, and then back down. You don't want to bend your elbow, and you don't want it to be a ballistic motion. Just a nice smooth punch up and punch down. Try to keep the rest of your body as still as possible. And he's just going to do a few reps. And to make it challenging, you can change the angle. I really like it in standing with resistance of some sort, and where you're really pushing against something. But to start with, on your back with a water bottle or a small weight, something like that is very good. Unless you aren't being challenged. You want to make it that you're working hard, but not that you can't do
All
it.
right. This is just another picture of the shoulder. I want to go back to this to kind of remind you to kind of basically remind you of everything that's in the shoulder, because once again, adhesive capsulitis, aka frozen shoulder, is usually just not it's not the shoulder freezing. I know they call it frozen shoulder, but it's a lack of motion, so it feels like it got stuck frozen. It's not that the shoulder actually freezes, but the loss of motion feels like you're stuck, like you're frozen in place. So you can have issues with one of the biceps tendons. You can have a supraspinatus tear. You can have a lot of tone in your subscapularis. Any of these issues, if not treated, and you just kind of forget about it and don't really bother with it, but start to restrict your motion, they can get worse. It's like if you leave a pear or a piece of fruit in the refrigerator, and you forget about it for a while. Okay, it might not be too bad, but the longer you forget about it and just let it sit there and fester, you're going to start to get that growth, that bacteria, that stuff on it, and then it becomes an issue because you got to clean up the whole refrigerator to get that bacteria out. It's just basically the same thing with the shoulder. If you let one of these other issues, which could honestly be small and easily treatable, if you just let it fester and just get worse and worse and worse over time, thinking, oh, it's going to eventually get better, but you don't do anything to make it better, you're going to start to have those problems that can lead up to that frozen shoulder. But the sooner you take care of some of these issues, the better your prognosis is going to be. All right. So we're going to talk about healing a little bit. Now, healing, the treatment program should honestly make the healing process go by a little bit quicker. It should work on improving pain, increasing the motion and strength, while also improving function, coordination, and stability. Initially, a lot of the work is going to work in the directions where there's minimal to no pain, just to make it easier. A lot of times, if you try to work in the direction where there is a lot of pain, it's going to just make things feel worse. Or if it doesn't make the situation worse, it's going to mentally make you think it's worse. And so you're not going to want to move or do it. So a lot of times we start off with small wins, just moving it into opposite directions and in the directions that are not quite as painful, and just get the blood flowing, loosen things up to allow you to go into that painful range a little bit more. And then you want to, and then as things to get better, you can go into those ranges a little bit more comfortably. You can go further into those ranges. You're going to progress and progress more into those painful movements. Now, you also want to make sure that your therapy program is being progressed. You don't want a program where you're doing the same 3-4 exercises from here into eternity. If I see you day one and you're still doing the same exercises and then I see you 6 months later and you're still doing the same set of exercises, there's an issue. I mean, yeah, the basics are important, but if you're still doing laying exercises where you're laying down and you haven't progressed to where you're lifting weights or moving objects around, you're not in a good program. And if all your exercises consist of 3 sets of 10 for everything, no matter what's trying to be accomplished, yeah, you might want to head for the hills then. Also, you don't want to jump too fast too soon. I've seen plenty of people who gave themselves a little bit of problems. They didn't do irreparable damage, but they made a little bit worse on themselves because they started off lifting no weights, and then they started to feel good and then try to lift 50, 60 pounds. True story. I had a guy who has shoulder issues. Can't tell you too much more than that. It was just a gentleman, probably about 10 years older than what I am now. He was having shoulder issues. He used to work out all the time before he injured his shoulder. And for 2 years, he hadn't went to the gym or anything because his shoulder used to always bother him when he went to the gym. And so he just kind of backed off of it for 2 years until he finally got sick of it because he couldn't get his shirt on without pain. So after therapy, probably about 2-3 weeks, he actually started to feel better again. And so he went up to the gym. I actually saw him at the gym. We went to the same gym, and I'm looking and not trying to say anything, not trying to disrupt the man. And he's trying to bench. I mean, it was well into the 200-pound range. And so I go over to him. I'm like, nah, you don't need to try this. And he just looks at me and he says, I got this. And I don't think he recognized me because, one, I know I look differently in work clothes and then in my workout gear because I have a hoodie on and all this other stuff on. So don't look like Dr. Jordan. But it just wasn't a smart move. So he tried to lift the weight and he got it up. But when he went to when he put it down to his chest and try to get it back up, it didn't happen. And so then you got to get somebody to come help you out. Well, that happens not with that much weight, but it happens all the time. Somebody goes from not being able to lift no more than about 5 or 10 pounds because the muscles have atrophied and they just haven't done anything with the shoulder to trying to lift a whole lot of weight, and they get discouraged because they can't and it hurt. When in all actuality is you need to make slow, steady progressions. You start off with like 5 pounds. Then once you can do a good amount comfortably, you try to maybe go up some more and go up some more and go up some more. But you never want to, I shouldn't say never, but it's usually not a good idea to make these huge jumps from I always tell my patients it's always good to test yourself, but Test yourself in small increments. Don't shoot for the moon too fast without doing the prep work. So the next couple slides just go through the normal healing times of the body in a perfect world. So I got it as grade 1, grade 2, grade 3. So grade 1 is like, if you think about it, it's a small sprain, a small strain, a little bit of aggravation, no big deal. Grade 2 is in that more medium, that mild to moderate, severe range, where it's still there, but you aggravated it. You made it feel not so good. Grade 3 could potentially be there's a good amount of fraying to a complete tear. Honestly, a lot of times, yeah, a grade 3 is usually a complete tear, but that in of itself should not scare anybody either, because people walk around all the time with torn rotator cuffs and torn shoulders without a lot of pain. But yeah, as you can see, grade 1, those are the issues that usually heal quick. So yeah, muscle is like 2 weeks max. If it's a grade 1, then a ligament like that sprained ankle, 3 days. Then you may get but then you see for like the tendon, it may be 7 weeks. And then you look at it for muscles, as it advances, it becomes 3 months. Then at the worst level is 6. Same thing for a ligament. It can be 6 months at level 2, and then at level 3, it's a whole year. And part of that is because muscles usually have have more bountiful blood supply. So the closer you are to a blood supply, the faster you're going to heal. So muscles have arteries in them, have capillaries that run along with them. So they're naturally just going to heal faster. And then you look for a tendon. You got 6 months for a laceration. And these are the normal, on average, healing times. Remember, diet, exercise, sleep patterns, stress, doing the right things to treat the issue can make it go quicker, and the opposite can be done. You're eating like crap. You're eating McDonald's for dessert and Hardee's for the Hardee's burgers for dinner and stuff like that. You're drinking a whole 12-pack. You're smoking. You're not sleeping at all. You're burning the candle at both ends. You're stressed about everything. All those things can slow down that healing process. So what may took somebody else in a perfect world 6 months, it can take you that year. So all of those things come into play. Now, for bone, it's a little bit different. A bone breaking is usually between 5 weeks to 3 months. Cartilage, like if you had a cartilage repair in your surgery, it could potentially take 2 years to be completely healed. And then like a ligament graft, had to graft on an ACL or something. At worst, it could be 2 years. If you're doing everything that you're supposed to do. And once again, just remember that these times aren't hard and fast. Some people will heal quick and some people will heal slower, just normally. But the more bad habits you keep, the slower it will heal. So during that healing process, it's best to start getting in some good habits. You don't have to go 100% good habits, but 80% good habits is going to help you out a lot. And just going back into nutrition, we talked about this earlier. It's very important. Like I said, vitamin C helps with collagen production, while zinc helps to improve wound healing. And proper amounts of protein protein, which you hear people talk about all the time. Recovering from surgery and other forms of trauma is very important. Um, Hopefully you're getting most of this stuff in your diet. If you're not, you need to talk to your doctor about what you should be taking, what if you should be taking supplements or whatnot. They need to do a blood test to see if you're lacking or if you have too much, because having too much of these things can be a problem also. Treatment. Once again, you need to figure out which stage you are in therapy. If you, I have people that I've gotten people that's in all the stages. That thawing stage or that pre-freezing stage, it's usually a little bit easier to treat. But if somebody's in that frozen stage where whew, it can be difficult to move. And a lot of times in that freezing stage, it's a lot more painful. They still have motion, but everything hurts. So it's important to try to figure out what stage you're in during the therapy. You still end up having the same goals, but you kind of have to work around things a little bit differently. And And as I said earlier, in early stages of treatment, I like to start off with distraction. Distraction is just moving, just creating some separation in that joint for a momentary piece of time, which a lot of times helps out with pain. It can get people to relax and help to get them moving. Just showing a bicep curl, a lot of times in the shoulder. It hurts to move, but doing things like a bicep curl, which remember the bicep still helps with shoulder motions, can help out a lot of times, can get some of that blood flowing to help out with movements. And then with the exercise, with the treatment, you have different different things you want to improve on. You want to improve on mobility, stability. Mobility is basically being able to reach above your head, being able to reach behind your back, and being able to do it safely with a load, being able to move in multiple directions with reduced pain. Stability is being able to move in that being able to maintain that position, being able to hold your arm out with a load, being able to push and pull something safely. So it's fighting gravity, stability. And then you, like I said, you have to focus in on function. Pouring your milk, washing your hair, wiping your tail, carrying bags, carrying grocery bags, picking up your kids. That's a big thing. Have a lot of people with shoulder pain that have kids and grandkids that don't really play with them anymore because it hurts. They don't carry. I've had a few people crying because they've had newborn babies or babies that are toddlers, and it hurts them to pick them up, to carry them in their arms. Babies no more than 20, 30 pounds. This is a full-size adult, and they're upset because they can't pick up their grandchild or their child, and it's a serious issue. And so that's been one of the things that we work on in therapy, is trying to get them so they can pick up that child, carry that child. I had people who just want to be able to carry the groceries from the car to the house. And so that's one of the functional things we work on. Or like I said, at one time I didn't really understand it, but I had one lady who was really, really worried about being able to comb her hair. Finding out, talking with her, finding a little bit more about her, she took a lot of pride in her hair and how she looked for work. And I mean, she could still put on her clothes, but being able to do her hair for work was a problem. And so that was something really important for her. And once she began to be able to do her hair, you start to see changes in her. How she was a little bit better. She was a little bit better socially. She was easier to kind of talk to because she that's something that was important to her. She was able to do again. So just those are some of the functional things. And something I didn't think about as a young therapist was being able to wipe your tail. I mean, I always thought you had two hands, but I didn't realize people got accustomed to wiping their bottom with one hand. So if you can't do that, it becomes an issue. And I've had grown men talking about they hate the fact that they had to go get a shower to clean themselves. And so being able to help somebody with that is important. So things like that you have to be able to talk to your therapist about, because those are things that we have to work on. We can assume that's something important to you, but if you don't tell us, we don't really know. Here's a fun little video I like to do with my people. So some stabilization exercise. So being able to hold against gravity. Exercises. So the first one is a pretty simple exercise. You take the ball, gym ball, basketball, volleyball, soccer ball, have it against the wall. You're just going to push in, and you're going to go clockwise and then counterclockwise. You're pushing into the ball the whole time. You're going to start to feel this in your periscapular muscles. Those are the muscles at the shoulder blade. And the next exercise, you take that arm that's giving you problems, and you'll just reach up and down. You're going to go up, pushing into the ball the whole time, and back down. And that's for your lower trap and your lats. So I would be remiss if I didn't do at least a little quick discussion of some issues that can cause shoulder pain that, if not treated, can potentially lead to that frozen shoulder. So the first one is shoulder impingement. And let me see if I can go back to this slide. So as you see, there are a whole lot of structures in this area. You got muscles, you got tendons, you got ligaments, you got bursa, you got bone. Then you also got to think you got blood vessels, nerves. Humeral joint, it's maybe 9 millimeters. And in that space, you have with your biceps tendon, you have the tendon for your supraspinatus. You had the cartilage, and then you had the parts of the joint capsule all in that space. So you have a lot of moving parts in that area. So imagine if something gets irritated and then it becomes inflamed. That's going to start to restrict movement. And so, because what happens is when a structure gets irritated, it starts to swell. And so, in a 9 millimeter space, so a space that's less than an inch, you have all those structures I just named. And so they barely fit in normally. But so, I didn't realize I was pointing in the wrong spot. But so right in here, we got that structure. So in that small space, you got all these structures that fit in. And if one of them swells, it starts to become a problem. And so now you're pushing up against it. Now, this is something, if treated early, it can be non-problematic. It can be a quick issue. But a lot of times it doesn't get treated early. The second thing is you have bursitis. So you see this bursa right here. A bursa basically helps to allow for a little bit more movement. You can see this bursa, it separates the tendon from the bone, so it allows things to glide over each other a little better. What happens every once in a while, this bursa can become inflamed. It gets real tender to touch, and you notice that it's hot in that area. So you can put your hand over it, and there's a noticeable heat. And then motions start to become restricted. With bursitis, a lot of times, abduction, the motion of bringing your arm out to the side, can become limited, because as you bring that arm out to the side, so your arm comes out this way, it starts to press on that bursa a little bit more. Then you have tendonitis. You can have inflammation of the biceps tendonitis. You can have inflammation of this I said biceps tendonitis, of the biceps tendon. You can have inflammation of the supraspinatus tendon, or one of the other tendons in that area. It's thought to be an overuse issue, because sometimes if you just kind of relax for a little bit and lay off the activity, or lay off doing the activity as much as you did, it does sometimes get better. The thing is, it's not always an overuse issue. Sometimes what happens with tendonitis is there's a weakness in one of the other muscles that assists with that motion, or that does that motion. And so one of the other muscles has to work harder to accomplish that same task, that same feat. And so it's like if you're trying to carry a couch, you're moving and you're trying to carry a couch. One guy takes one end, the other guy takes the other, and all the merry. You have a little bit of difficulty sometimes trying to get into the door. But if everybody's doing their job, it's not that big of a deal. You may be sweating a little bit, but not that big of a deal. What happens though, if one person is not doing their job, and so you got the majority of the weight of the couch on one person, so it makes getting in the door harder. It makes carrying it off the truck harder. It makes walking it into the house harder. It can still be accomplished, but there's more stress and strain on that one person that's doing the majority of the work, because his partner's not doing his part. So the other thing with tendonitis is you find out where you have the this use component, the weakened component, and you work on improving that strength. A lot of times with tendonitis, we may do eccentric exercises to work on the lengthening of that muscle, to the strength and going in the opposite direction. Usually with tendonitis, the motion is full, but it may be painful. Then there's it's another small area. It's actually a little bit smaller than the subacromial space. So the area in here, it's a little bit smaller than there. And so it's the same thing, working on improving the movement and function while increasing strength.
Another thing.
So those are just the slides with talking about the shoulder impingement, bursitis, and the tendonitis, and then the second side of impingement. All right, so we're going to show you a little video about what happens in therapy. Just a quick assessment of some of the motion and some of the hands-on things we do with the patient. And as you can see, this is my mom. She had some shoulder pain and she was at church, so came down there to work with her.
What's the deal, good people? It's Dr. Chief Jordan with Fearless Physical Therapy. I'm here today at 3005 Share Road, Hampton, Virginia. This is Deeper Life Church. Got a call from one of the church workers that they're doing some work and the shoulders bothering them a little bit. So we're going to run through some of the things we go through for initial evaluation for a patient with shoulder issues. So first, normally we'll have the person take their shirt off, but we're going to keep the shirt on. And I'm going to take a look at posture, just basically how the person is standing, sitting, the alignment, see if everything lines up or there's any atrophy in the muscles. Sometimes you see somebody with a SC joint that's kind of bulged out or an AC joint that's depressed or recessed a little bit. How we stand, and you may see that the hands are internally rotated or that they're curling one side higher than the other. The next thing on how we do, after asking the history, is going to have you raise both hands above your head. And so I'm looking for if both hands they get about the same height. Sometimes you may see somebody this one up with one hand all the way up and the other hand like this. Okay, so that's an issue. Or you may see somebody with the motion is kind of jerky and they have to fight their way to get up. All right, take that. Now bring your arms up to the side and I'll hold your head. Okay, and so pay attention to that. Normally have them with their thumbs here and try to clap above their head. Okay, take that. All right, so you put one hand behind your back, please. And so I take a measure where that is. Now you relax. And the other hand behind your back. Now relax. And so that was different. So have one hand behind your back like here. And relax. Go ahead, put it down. And now the other one. All right. So I noticed that hurt a little bit. Yes. All right. Stand up for me. I'm going to have you turn around. This one's going to be important. Next thing we'll have to do, put one hand behind your back and then the other hand behind your head and see if you can touch them together. And so you will see where the space is between the two hands. All right, and let's relax. We'll switch. All right, hand back. And so you see her say she can't do it. All right, so go ahead, lay down for me, please. On your back, please. And I'm going to give her a little bit harder time than I would give most people because this is the person who raised me for 18 years and just make up for some of the spankings I got. All right, so then I will move their arms, just relax this one. I'll move their arms around and seeing how much motion they have. So like here, will start to resist. And I'll do that in all the directions. And then for treatment-wise, some of the things I will do is I'll have her right here, push against my hand, and back. Now push this way. Give me a little bit of resistance. All right? Push this way. And now push this way. All right, so you're going to push all the way down again. And I wouldn't normally do all four in a row like that. I would do one for some reps. Now push back this way. And then I will do the other. But right now, since we're just showing you guys, we're just going to do it like that. So push against my hand. And I push against my hand. This way. All right, and then this also becomes a stabilization exercise. I'll put a ball or something in her hand. Tell her to hold it right here. And then just keep your hand right here. Okay? So I will gently give some perturbation. And the idea is for her to keep her hand right here. And so keep it right there. And so I will slowly get some resistance. And then once she doesn't move any, I will then start to speed it up, make it a little bit harder. Okay, and relax. And so I like to start off with any treatment that's intervention that I do with a little bit of distraction at that joint. So what I will do is I will take her arm and relax it for me. I will cuff it and I will just distract the joint. Usually distraction provides a little bit of relief for the patient, so it's normally pretty good to do, but once again, everybody is different, and I know I'm not in the right position right now, but this is just me kind of showing. If I was actually doing it, I'll have belts, the table be up a little bit higher. How's that feel? Is that all right, or does it hurt? All right, and so I'll get ready to try to relax. All right. And also, since we're talking about adhesive capsulitis today, you would take a look at the subscapular.
Thank you. I appreciate those of y'all who were able to come in. I heard that there were some people that tried to get on, but once I shared the screen, I didn't see it. So I apologize for that, but the replay will be available. And if you have any questions, just feel free to contact me. All right, you all have a great day.